we have no disclosures to make in terms of finances. Sorry, I always have to find the control bar once I'm in presenter mode. No disclosures to make. Today's presentation is on preventing provider burnout in chronic pain and opioid use disorder treatment. And the objectives are that you will be able to identify both system and individual level predisposing factors for burnout and fatigue, define burnout, compassion fatigue, secondary traumatization, and vicarious post-traumatic growth, and name evidence-based, evidence-supported advocacy approaches, self-care activities, and perspectives to navigate risk. So starting out big picture, just with the state of New Mexico in general, and with traumatized populations in general, providing services to highly traumatized populations does increase our vulnerability to traumatic stress as providers. That includes vicarious trauma, secondary traumatic stress, and compassion fatigue. I'm thinking of the state in general, and then Albuquerque in particularly as its cynosure. Albuquerque is consistently ranked in the top 10 most dangerous cities in the US. So the patients that we're working with in this area and across the state are embedded in a context of significant community violence, and often that's going to show up in the work that we do with them. Putting this into the perspective of adverse childhood experiences, which I believe most of you are familiar with. At the national level, about 1 in 10 children have experienced 3 or more ACEs, whereas here in New Mexico, that's actually 18%, quite a lot higher. Only Arizona's ACEs scores were comparable. So that's big picture in terms of how working with traumatized populations can increase our vulnerability to traumatic stress. And then we'll look more closely in a moment about specifically working with OUD and chronic pain. So starting out with definitions, looking from left to right, burnout and compassion fatigue, it's important to remember, are actually distinct constructs, but because today is an overview, we're going to look at them together. And they are importantly very distinct from secondary trauma and vicarious trauma. So as you look from left to right across this chart, burnout and compassion fatigue fall under the category of just general job dissatisfaction. It doesn't have to do specifically with trauma work, whereas secondary and vicarious trauma specifically have to do with working with traumatized populations. In secondary trauma, your symptoms would mirror an individual patient's trauma experience. So that means that you would be manifesting some of those trauma symptoms yourself. Whereas with vicarious trauma, it's more cumulative and chronic. It's about seeing traumatized patients over time and starting to show different dimensions of those various trauma symptoms. So we're going to focus today on burnout and compassion fatigue. So this is much more related to workload and environment, and it's usually cumulative as opposed to the secondary and vicarious trauma being related to empathy. But what all three have in common is a low feeling of accomplishment. And we're going to focus on that a lot today because it's a really strong recurring theme across various types of burnout and compassion fatigue. With burnout and compassion fatigue, the remedy does have to do with time away, vacation, potentially change of work. Whereas with secondary and vicarious trauma, the remedy is therapeutic self-care, and it usually requires more than just time away. It's important to take seriously. So starting with symptoms of burnout and compassion fatigue related to work. Avoidance or dread of working with certain patients, reduced ability to feel empathy towards patients or families, frequent use of sick days, lack of joyfulness, cynicism, and lack of satisfaction with work. There are a very vast array of non-specific emotional and cognitive symptoms as well as physical symptoms. So if you're experiencing things like anxiety and restlessness, headaches, sleep disturbances, etc., it doesn't mean for sure that you have burnout or compassion fatigue, but these are important indicators to be looking out for if that does seem to be on the radar. So we wanted to keep a fairly full list here. So what are some of the vulnerabilities that are associated with developing burnout and compassion fatigue? One of the biggest ones is the construct cognitively of believing that your actions will not make a difference or never seem to be enough. It's very difficult to find your work meaningful if you're feeling this way. Another big one is experiencing problems with the system that are outside of your control. So that can have to do with having a very high patient caseload, high acuity caseload, working overtime or extra days a lot, and particularly at the systems level, lack of trauma-informed care or managerial support. Also outside the workplace, experiencing personal issues or for other reasons, issues that might affect your energy or your personal resources that you bring to the job. On a more interpersonal level, over-identifying with patients. This is really commonly a setup for burnout and compassion fatigue. It's hard to be objective and to do your best work if you're over-identifying with patients. And then lastly, kind of common sense, overlooking serious patient symptoms that impact patient outcome. And that's a bit of a chicken and an egg thing, because often people who suffer from burnout and compassion fatigue do end up with these kind of oversights that they wouldn't be making if they were feeling more resilient in their work. In terms of preventing and ameliorating compassion fatigue and burnout, there are some sort of big picture strategies here. Firstly, recognizing the symptoms of compassion fatigue and burnout. That's why we have these whole lists here. Learn to ask for help. Don't cover it up. This is important because a lot of healthcare practitioners have sort of implicitly been inducted into the culture of you're not a team player if you speak up about feeling overwhelmed, or they don't want to be seen as complainers. But it's important for yourself as an individual and for your team that you promote this culture of openness about asking for support when it's needed. Being aware and accepting the limitations of your job and yourself, particularly learning to say no in professional contexts, which can be a very difficult thing for providers who find their work very meaningful. Understand that your pain is understandable. The work you do is intense. So this is about normalization. A lot of the times when people are experiencing burnout or compassion fatigue, they internalize it and take it upon themselves. They think it must be something I'm doing wrong. Whereas really it would be unusual for a provider to work in the context that we do and not find it painful at times. It's very difficult work. Remind yourself daily that you do make a difference and what you do matters. It can be really helpful to hold on to things like thank you notes, or just mentally hold on to positive feedback from patients and coworkers, because it's easy to lose track of that when things are not going well. Maintain discipline in daily responsibilities and duties, and similarly organize your time so you can concentrate on vital tasks. That's about making sure you don't get overwhelmed with the little things so that you can concentrate on the important things. Take time out during the day to renew and recharge. So this is about the sort of small, incremental, interstitial things that you can do to take care of yourself throughout the day. It's not just about making sure that you use your vacation time and that you're exercising out of work and those kind of big picture things. It's about a mindset during the day, every work day, that there is time and space for you to take care of both yourself and your patients. And then lastly, distinguish between stressful aspects of your job or home life that you can't change and those that you can. This is practicing what we preach, because as providers, usually at some point, we're telling patients to pay attention to what they can and cannot control. And it's very important for us to do the same in order to prevent and ameliorate compassion fatigue and burnout. All right, this is a graphic from the National Academy of Medicine that does a good job of showing all of these sort of nested, almost ecological layers of how patient well-being is contained within the clinician-patient relationship, which in turn is ensconced within the clinician well-being sphere. And that is held within these mostly larger sort of big picture factors that we as providers do not have individual control over. The only tabs there that we have control over are personal factors and skills and abilities, the blue ones. All of the yellow ones, things like rules and regulations or the practice environment, these are things that we have no direct influence over, although something we'll discuss is the importance of advocacy and political action in order to, over time, shift those things to make it a better place for patients as well as ourselves. All right, so we'll look at, it sounds like maybe somebody is about to say something. Is anybody? Okay. All right, so for providers working with OUD and chronic pain, I was looking at the qualitative literature and it lines up really nicely with that graphic. So some of the biggest systemic and administrative barriers that they identified as contributing to provider burnout were hospital policies that negatively affect patient care. So sort of the definition of one of those big picture issues that's very difficult to individually influence. The biggest ones there were pressure to discharge patients as quickly as possible, with little to no focus on broader social determinants of health or stability. So that's that feeling of the revolving door, where you put a whole lot of time and energy into managing acute symptoms with a patient, having to discharge them very quickly as soon as they nominally reach stability, and then seeing them come back into the hospital, often in a deteriorated state pretty quickly, because they've been released too quickly into a community that's not supportive of that stability. A very related component in terms of what contributed to burnout for these providers was limited resources and restrictive policies that they felt created barriers for care. For the addiction medicine specialists, that particularly focused on policies that limited the use of buprenorphine or methadone. These providers recognize how effective these medications are, and it's incredibly frustrating to have to try to find ways to work around hospital and regional regulations that make it difficult to administer to the patients as is best for them. In a related sphere, community resources that were severely restricted or unavailable, or lack of coordination between community resources. So I'm sure many of us have had the experience of trying to get these patients set up for discharge only to see them slip through these safety nets. So all of this leads to feelings of powerless and hopelessness. This is the opposite of autonomy, and feelings of autonomy are really what we're going for when we're looking for preventing burnout and compassion fatigue. So a related quantitative survey of physicians practicing in interventional pain management found that 67% of them responded that in-house billing was responsible primarily for their increased level of burnout. So another point to consider in terms of those things that are really over our head and they're really structural that contribute to burnout. Similarly, 73% responded that EMRs were one of the causes that contributed significantly to their burnout. And nearly all of the respondents, this was a survey that was done in 2020, had been affected with a reduction in interventional procedures because of the protocols related to COVID-19. So again, just really emphasizing all of these things that happen outside our immediate sphere of control, both because it's important to keep in mind what we individually can control and also to keep in mind what we can advocate for and what we can change over time. So on that note, the idea of recognizing the role of the system, I took a few points wholesale out of this very good book called Leaving It at the Office by a couple of psychologists who research provider burnout and resilience. I use their same wording because they're very eloquent and it's a great way to make some really big points fairly succinctly. But the whole idea here is about taking a perspective-based approach to burnout prevention, and in particular, that idea of recognizing what's the difference between what is wrong with the system and something that I might be able to do different individually. So some of these points are: recognize the grim truth that organizations create much of practitioner exhaustion and demoralization, refuse to blame the person when institutional causes operate. A very important one here: beware the toxicity of chronic moral stress. Repeatedly rendering suboptimal care erodes your soul. There's a lot of research showing that these kind of nets of what we as providers sometimes feel like are counterproductive regulations or policies and how they undermine our ability to provide the care that we were trained and that we want to do. That in itself is really a dramatic contributor to compassion fatigue and to burnout. Resist the pressure of managed care to define yourself as a nameless and disembodied provider. Maintain your individual identity as a distinctive practitioner of healing. This is again about reclaiming autonomy and distinctiveness and finding a way to bring your own unique brand, of healing to your work. Search for ways to create greater freedom and independence in your work. When you're more in control of your workload and your schedule, you'll experience less burnout and more work-life satisfaction. Again, going back to autonomy and a sense of meaningfulness in your work. And lastly, borrowing from a medical model metaphor, beware of false interventions and short-term fixes in dysfunctional institutions. Treat the systemic roots, not just the acute symptoms. So once again, wrapping back to, don't take it all on yourself. Remember to recognize that sometimes these issues go far, far deeper than just your individual ability to manage the workload, and choose to advocate accordingly if that's the energy that you have for it. So in terms of some broader points for taking action to prevent burnout, on the systems level, creating positive work environments, the social context that we're living in day to day is going to have a huge impact on our mindset and our well-being. Talk with colleagues and leaders and advocate for change. So this is about that, delayed gratification. It's a long-term change, but very important one to make usually. Address burnout and training at the early career stage because we want to start a bottom up from the paradigm. Push for trauma-informed care policy and procedure. Reduce tasks that do not improve patient care. So that it has to do with making sure you're not getting more administrative burden than you absolutely need to. Improve the usability and relevance of health IT. So that's going back to that finding that EMRs and billing were a significant contributor to burnout. And reduce stigma and improve burnout recovery services. So that's again about making it an open conversation so that people feel empowered to talk about it. And also importantly on this point, creating a national agenda, a research agenda on clinician well-being to really demonstrate what a priority this is for all kinds of healthcare providers. So on the individual preventive level, coping, a lot of people, when they hear this word, they think of it as sort of a passive thing of just getting through something, but it actually etymologically comes from the root coup, which is to meet in battle. That's a good way to remember that when you're doing it right, you're being very proactive. You're kind of on the offensive, so to speak. So that's about making conscious efforts to solve personal and interpersonal problems rather than sort of waiting to see how they pan out or being passive. Seeking to master, minimize, or tolerate stress or conflict in an effective manner, so being skillful. And remembering that professionals who take an active stance in coping with their own stress can not only prevent the negative impact of working with traumatized clients, you can also very effectively model coping for your clients, which is a very important part of self-care provision. Similarly, on the individual side, there's a really strong evidence base for some specific domains of self-care. These include prioritizing close relationships, maintaining a healthy lifestyle, fostering recreational hobbies and activities, practicing mindfulness and meditation, and pursuing spiritual development. What this is going to look like for each of you is going to be very different according to who you are as an individual. It's really important to personalize your self-care. So a few different ways to do that, and that's back to that same book I mentioned earlier, have to do with diversifying your approaches, both because novelty is important and also because you, just like you would with a patient, you don't want them to rely on just one strategy to help them get better. You want to make sure you have a few options. One that people often don't consider is that because of the work that we do, which is largely cerebral and sometimes very emotional as well, we want to counterbalance that type of work with pursuits that are sensory, that are rooted in sensory awareness, or that have concrete and achievable goals. So whereas at work, we're doing a whole lot of paperwork and emails and interfacing with clients in ways that don't have really clear outcomes a lot of the time, away from work, we want to do things like the chop wood, carry water philosophy of do things that you get to see right away, the impact that you had, and that you created a specific outcome. In terms of sensory awareness, that's moving towards using taste, vision, hearing, touch, because these aren't faculties that we get to exercise very often in our work. Lastly, on this front, remember to convert intentions into reliable behaviors. We know as healthcare providers, it's one thing to be ambitious about making life better for ourselves and our patients, and it's another thing to translate that into concrete behaviors. So making sure that intentionality becomes realized in the real world. I do want to briefly mention, because it's something a lot of people don't know, that there's very strong research evidence that providing EBPs, evidence-based practices, is in itself a buffer against burnout. So delivering EBPs is negatively correlated with burnout, and use of non-EBPs is positively correlated with burnout. So really very interesting research in this area. A lot of it has to do with providers' knowledge and confidence in delivering EBPs. But I always want to make the point, because sometimes I think this can be misinterpreted a little, that this is not a reason to give people who are providing EBPs larger or harder caseloads. It just means that this is, an important strategy in terms of best practice in a variety of domains. So in terms of sort of higher order interventions, we've looked at more particular strategies, but we want to wrap up with the idea of philosophies that guide your work and make it feel coherent and meaningful. And this is about consciously and mindfully connecting to why you choose this work. Why is it unique and why is it meaningful for you? And what outlook is going to carry you through the inevitable frustrations of the difficult work that we do? This is summed up in, if any of you have read Viktor Frankl's Man's Search for Meaning, one of his famous quotes is, "What is to give light must endure burning." So that philosophy of pain paired with meaningfulness. So a few examples here. I drew again from that qualitative literature from the OUD and chronic pain providers, some of the main themes that they found in terms of why their work was meaningful. Was that engaging in meaningful work increased resilience. So they found that they themselves were replenished by the meaningfulness of the work. Specifically in that making a concrete difference in patients' lives. Often this was by starting them on evidence-based medications, and then also being able to successfully provide patient-centered care, particularly to patients experiencing stigma. Similarly, connecting with and supporting underserved patients was found very rewarding. That's especially during their times of exceptional vulnerability, and patients who frequently encountered stigma in the system were often highly appreciative of the care and support of knowledgeable providers. There was a similar finding that providers find satisfaction and meaning in advocacy and education. So again, that's those big picture sort of maneuvers. Some examples were participating in institutional QI projects or higher level advocacy work to improve patient care. And then something I thought was important on that social context side was that many providers noted that they appreciated the culture of advocacy among their colleagues and enjoyed working with other similar-minded individuals. There's a lovely quote here that just made me think of how I feel about working with a lot of the people I've gotten to work with in this community, which is, I feel like addiction medicine providers are people who have a very, very strong sense of social justice, which is a pleasure and really important to me to work with people who are thinking about that in their work. And then also people who are interested in questioning the system and rules and trying to change it, which is also a very special group of people. So we'll wrap up with a couple of constructs that fit with this big picture philosophy. Post-traumatic growth is summed up by Hemingway's quote, "The world breaks everyone, and afterward, many are strong at the broken places." An extremely brief overview of post-traumatic growth with patients is when they go through a traumatic incident, but come out on the other side feeling as though they actually are a better person or feel better about themselves in the world, despite, and in some senses, because of the way that they responded to the trauma. So that can be things like increased recognition of personal strengths, a sense of perspective about what's important in life, this sort of thing. And vicarious post-traumatic growth is exactly what it sounds. So that's when clinicians get to vicariously enjoy those post-traumatic growth benefits. So some of the ways it shows up most often for clinicians is through perceived psychological growth. Those are things like higher levels of spiritual well-being and a greater appreciation of life, a better big picture perspective. Lastly, for the higher order interventions, I do want to give a plug for gratitude. I think this is often misunderstood as a sort of don't complain, be thankful for what you have in your work, and that's not at all what it's meant to be. The research on gratitude really emphasizes that it's about a balanced view, and in the work that we do, which is so difficult and in so many ways is very focused on some of the harder parts of life, it's important to be able to counterbalance that by making it an active practice of recognizing when patients do well, of recognizing the amazing community that we're ensconced in as providers in this field, being able to shine a light on the things that do go well and are meaningful for us. And the research on gratitude is very strong. There's so many benefits. It's associated with more frequent experiences of happiness, hope, fulfillment, and meaningfulness. Grateful people are more stress resilient. It strengthens social ties and self-worth. There's so many good things. So I have included in the resource list at the end of the slides a few different links to gratitude exercises and different ways that you can sort of build your gratitude muscle. And on that note, I think on time, yes. I am feeling grateful for you all and for this community, particularly on this topic. It's important for us to feel that we are in community around this topic. And I'm so glad you all were here today. Please do check out the resources if you think they would be helpful to you. And I guess, do you all have any questions or comments before we head into the case discussion?